Welcome very much to our Research into Practice webinar series, where we are inviting each of our 11 research units to come and present about work that they're doing, what's that going to mean for clinical practice, and give you an insight into what the research and innovation team do. So I'm very pleased today to introduce the Complex Trauma and Resilience Research Unit. We call them C-TRU. They've recently ended one of their studies called Staff Time, and they're going to present about their findings and methodology today. So without further ado, I'd love to introduce you to Professor Katherine Berry, who's a Professor of Mental Health at the University of Manchester, and Dr. Kate Allsopp, who's a Research Fellow at Greater Manchester Mental Health, both of whom worked on the Staff Time trial. I'll hand over to you.
Okay, so I'll just give you a bit of background. So the Staff Time study originally developed from another study that we were doing looking at increasing access to psychological therapy on inpatient wards. As part of that study, we had psychologists based on acute mental health wards, and we were noticing that psychologists were spending a lot of time supporting staff in relation to serious incidents. And violence, aggression and assaults on acute inpatient wards happen a lot to service users, but also to staff. It's not just being the recipient of violence and aggression and assaults. It can also be experiences of witnessing or hearing about past experiences of abuse, witnessing self-harm, or the process of even restraining people can be stressful for staff too. So people were talking to us about the negative effects of those incidents and the effect it was having on their well-being. When you look at the data, it's probably grossly underreported because a lot of incidents don't make it into reporting systems. But when you look at the figures that are reported for, say, something like physical assault, it's actually really high for mental health staff. Mental health staff are disproportionately affected compared to other members of the health service. So when we decided that we wanted to do more research in this area, we did some preparation work. So one of the first things we did was talk to people on the wards about their experiences of these serious incidents, and they told us about stigma. So there's a perception that people needed to sort of get on with their jobs and to acknowledge or to admit that these things impacted on well-being was stigmatised. There's a particular perception that as mental health staff, you should be able to handle your own mental health, and to acknowledge that there was issues was a sign of weakness in some way. And that made it difficult for people to talk about issues and therefore to get help. People also told us that there's particular difficulties in seeking support and also receiving support when they did ask for support in relation to abuse that targeted identities. So racial abuse, abuse targeting sexuality or gender identity, or abuse targeting disabilities. We also carried out a Freedom of Information Act survey, which under the Freedom of Information Act, you can request anonymised information from organisations, including NHS trusts. So we asked all the mental health trusts in England what policies they had in place in relation to the management of serious incidents, and particularly the provision of support for staff. The survey revealed that actually around half of the trusts didn't actually have anything formal in place, or at least on paper, and those that did, it was largely in response to serious incidents after they'd happened, as opposed to kind of preventative measures in relation to staff wellbeing. So proactively targeting staff wellbeing ahead of kind of a serious incident happening. So that was very few trusts that had that level of provision. And when we also looked at the policies, there was only a handful that specifically mentioned that staff for minoritised groups might be particularly vulnerable to these incidents and might require kind of, or might experience more difficulties in getting support. Just move on to the next slide, please. So on the back of that preliminary work, we got funding for the National Institute of Health Research to do a big qualitative study exploring people's experiences of serious incidents on the ward, and in particular what supports were available, what was their experience of getting those supports that were available, what people did to kind of help prevent, or what trusts did to help prevent the development of mental health and emotional wellbeing problems following those incidents. We also, given the work that we'd done with staff prior to the study, we also wanted to specifically explore the experience of minoritised staff in terms of what they're experiencing on the wards, what supports they were getting, why it was difficult to get the help that they needed. And the idea with that work was then to develop some recommendations for best practice. Okay. Take on to Kate will talk to you now about the methods and the findings of the study.
Thanks, Katherine. So what we did was we had a fantastic research assistant called Emily Harris who conducted interviews with staff across England, and she did 43 interviews with staff working on acute inpatient mental health wards. And we wanted to include any staff who worked on wards in any capacity, so including those who we thought may have more difficulties accessing support, so including, for example, admin staff, staff who worked in estates and facilities, or domestic staff, as well as bank and agency staff. We also did 10 interviews with what we called senior stakeholders. So these were people who were regional or national experts in terms of policy, staff support, or in terms of equity, diversity, and inclusion. And as Katherine said, because we knew that some groups may find it more difficult to access and receive support, we had a target where we wanted to include at least half of the people that we interviewed being staff who identified with having a protected characteristic or one or more. So in the end, we had 77% of the people that we interviewed were identified as being from some kind of minoritised group, whether that's being from an LGBTQ community, from a racialized community, or having a disability, being neurodivergent, and so on. So I'll tell you a little bit about who took part. So these are just some slides just to give you an idea of the demographics of people who took part. And so these are the ward staff. We asked all of these questions from everybody who took part, but obviously answering was optional, and we didn't have any predefined categories. So we reported what people said in response to these questions, rather than asking them to fit into particular categories. So here we've got the spread of ethnicity and sexual orientation across the 43 ward staff who were interviewed. And here, staying on ward staff, the spread of neurodiversity. So, for example, people identifying as autistic or having ADHD, disability, whether that was physical, emotional, or neurological, and gender identity. And then here, these are the demographics of the senior stakeholders who took part. So there were only 10 of these, a slightly less diverse group. But here's the spread across ethnicity and sexual orientation. And then here, looking at neurodiversity, disability, and gender identity. That just gives you an idea of who took part. In terms of the findings then, so we asked people about causes of distress on the wards, and we found kind of three main themes really in terms of what was causing staff distress on wards. So these were incidents, persistent stressors, day-to-day stressors, or work-based issues and pressures. So we categorised incidents as things like violence, aggression, and assaults. Witnessing self-harm or self-injury, and less frequently deaths on inpatient wards. And also identity targeted assaults. So as Katherine said, anything that we're describing as identity target was something that was directed towards somebody's identity, whether that might be LGBTQ or ethnicity, or targeting a disability, for example. So here that could be a racially motivated attack, for example. So these are the sort of more severe kind of incidents. And then in the middle column, we've got persistent stressors. So what we're calling a persistent stressor is something like, it's really describing the build-up of kind of multiple lower level sort of incidents or things that happen. So this is more about the sort of day-to-day, daily stress or fear or anxiety, or verbal abuse, particularly identity targeted abuse as well. So for example, racial slurs or homophobic slurs being used targeted towards staff. So things like these were sort of happening on a really kind of daily or very frequent basis. So it's that kind of build up of these persistent stress. And then allegations and investigations, which whilst could be very serious, were also things that sort of go along in the background, causing that kind of stress over a period of time. So these would be allegations made by patients towards a member of staff, which rightly, of course, are need to be investigated. But even when the member of staff hasn't done the thing that they've been accused of, that stress is still there for the that they're under investigation for a period of time, which can go on for a very long time. And then in the last column, we've got work-based pressures. So organisational pressures might be things like staff shortages or staffing on sick leave, reliance on kind of bank and agency staff. So staff who are less familiar with the ward and don't have those kind of relationships on wards if they're on that ward for the first time. So lots of participants talked about staff shortages and these kind of ongoing organisational concerns. Individual pressures or stresses might be, as an example, where a staff member with a disability might have reasonable adjustments needing to be made, but perhaps they may be struggling to access those reasonable adjustments, for example, getting time off to attend medical appointments or needing more flexible working, for example. And then microaggressions and discrimination. So these are in this column because people talked about things that were coming from colleagues. So, for example, international staff or staff from kind of diverse ethnic communities might have microaggressions, like colleagues mentioning their level of fluency in English or the food that they eat. Example like this, or could also be for a staff with a disability, for example, maybe feeling like colleagues don't recognise or believe that they have that disability and need reasonable adjustments. So these three just really give an overall kind of picture of the types of things that are causing distress and stress for people on wards. And here are some examples of quotes from staff, just really illustrating that middle column of persistent stresses. So, for example, I'll read out a couple of these. The Black African nursing assistant said, "Sometimes when I think about coming to work and I think they're going to abuse me, I'll feel emotional. We're coming here to receive all of this abuse." And the nursing assistant in the top right corner said, "There's racism all the time. It's basically every night. Black staff are being accused a lot every month of sexual assault." So there was a feeling as well that staff from diverse ethnic communities were more likely to be have accusations made and therefore have to undergo investigations with work. I'll just give you a moment to read those other ones. So the impact on staff, as you might expect, can really impact on staff's mental health. Some people talked about being diagnosed with post-traumatic stress after something that had happened on the ward. People talked about anxiety, stress, depression, and lots of people spoke about feeling burnt out. And inevitably that often has an impact on people's personal life and their relationships, and feeling very burnt out and coming home and not feeling like they have enough for their family and things that they like to do outside of work. People spoke about the impact on physical health and sleep. And inevitably, all of these things have an impact on service delivery. Sometimes people spoke about being so stressed and busy that they weren't able to offer the level of care that they would like to because of all that was going on wards. Some staff members had told us that they'd left inpatient work entirely and they were now working in community services instead because they felt too burnt out, or because of incidents that had happened on inpatient wards that they felt that they couldn't go back. So I'll just give an overview then in terms of the current support that people were receiving and some of the sort of the limitations with that. So in the top left corner, people spoke about incident support. So after an incident happened, sometimes debriefs or support meetings were organised. But what we heard was that there was a really high threshold for that. So it was only after the most severe of incidents. So for example, where there's been a serious injury. And there were, although kind of lower level incidents happened really frequently, some staff members spoke about only ever having received a debrief once or twice in their career. So these are really not happening as often as they perhaps should do. In terms of psychological support, so things like accessing therapy for post-traumatic stress or depression, a few staff members spoke about receiving this kind of psychological support, and where they had accessed it, they found it really helpful. But actually, most people hadn't managed to access anything, and often things like really long waiting lists stood in the way of people accessing more formal support like therapy. Support for specific groups, so particular staffing groups or staff from LGBTQ communities or staff from diverse ethnic groups. Now, support on the wards was very limited for these staffing groups, and I'll speak more about that later. But actually, off the wards, staff found that staff networks within trusts were a really helpful source of support. So, for example, race equality networks or LGBTQ networks, disability networks, and so on, because people really felt like that was this kind of safe place where they could access support, where people really understood and got their experiences. Moving on to the bottom line then, in terms of support that people saw outside of the ward, some people described some really positive interactions they had with kind of specific roles that were off the ward. So professional nurse advocates have a role in kind of training and supporting staff, and some participants describe really positive experiences by getting support from their professional nurse advocates in their trust. We also spoke with some international support staff and international staff, and where there are international staff support networks, people spoke very positively about those and found them very useful. Again, really having that input from people who understood their experiences and been through similar things. In terms of manager support, when it worked, manager support was really important. There were certainly very mixed experiences described by participants, and it felt that there were kind of pockets of really excellent support. So people talked about really helpful experiences of support by their managers who made the time to speak to people about their experiences, listen to their concerns and kind of check in after incidents and so on. And that could really make a big difference for people. People did also describe experiences where they had much less support from their managers and they didn't really feel like they could go to them with concerns and that they weren't necessarily there for support. So quite mixed. We did also interview some managers directly, and managers spoke themselves about not necessarily being well supported. And often they felt that they were so busy with other pressures within their own work that actually they weren't able to offer as much support to their staff teams as they wanted to. So there's pressures from kind of on managers' support on managers as well. In terms of peer support, this was another aspect that was really often really relied upon, and there were really amazing examples of people really going above and beyond to support their colleagues and helping them to get what they need. But again, you can sort of see how there were different groups who perhaps don't have those existing relationships within staff teams on the ward. So either staff like bank and agency staff who aren't necessarily on the same ward all the time, so don't have those existing working relationships with colleagues, or staff who like domestic staff or estates and facilities staff who again aren't routinely on the wards, or they don't necessarily have that same staff team element. There isn't necessarily the peer support there, so you can see how people maybe missed out from that peer support opportunity. I'll speak to you a little bit about the kind of barriers to accessing support, and here's the sort of range of some of the barriers that people experienced on this slide, and I'll focus for now on the top line. So inequity of support access was certainly something that we heard from participants. So I've mentioned some aspects around different job roles. So for example, when people are not permanently on the ward all the time, they may have less access to support. So for example, if a support meeting or a debrief is organised after an incident, often that wasn't organised in the same shift. So it meant that if it's on a different shift, especially staff like bank and agency staff may not be able to access the debrief meeting if they're not on shift the next time. And staff like domestic staff, estates and facilities, they may have been involved in an incident or they may have witnessed an incident, but again, because they're not on the ward all the time, they may not necessarily be invited to any kind of debrief or support meetings, which means they would miss out on that element of support and kind of processing what's gone on. And in terms of identity-based abuse or incidents, this was often either dismissed or not called out. So staff spoke about people not saying anything, so not stepping in and saying, actually, that's unacceptable at the time of something happening, or that even afterwards, people didn't tend to check in after racial abuse, for example, and sort of say, are you okay? I saw what happened. And I guess from the other side of it, some staff spoke about not really feeling confident and not knowing exactly how to support people after identity-based abuse, not wanting to say the wrong thing, or felt that they didn't have enough kind of training and information. And so what that really means is that participants generally, there was a kind of perception that trusts in the NHS in general weren't doing enough to support people after identity-based abuse incidents and so on, or doing enough to challenge systemic inequity and discrimination within organisations. So this was a real element that was missed. And then if we move on to the middle in terms of beliefs and perceptions about support, there was a real culture that was mentioned throughout interviews that actually this kind of witnessing or being involved in or being on the receiving end of violence and aggression or abuse was just part of the job. And that kind of culture really stood in the way of people accessing support because of the beliefs around this is my job, I should be able to manage this, I shouldn't need extra support, or everybody goes through this, I should be able to cope with it. So I'll show on the next slide some quotes illustrating that. And then on the right hand side, lack of proactive support. So what we mean by this is where people aren't necessarily checking in directly with people to say, are you okay? What's happened? What do you need? What kind of support do you need? And even kind of well-meaning managers where they might say, my door's always open. It still means that the onus is on staff to then go and seek out that support. So really when people are proactive, that made a big difference. So that was a clear barrier. I'll just move on to some of the quotes around the kind of culture around it's just part of the job. So the bank healthcare assistant on the left saying, oh, it's do your shift, suck it up and go home. They had this feeling like that's how you just have to kind of get on with it. And then on the bottom, the mental health professional, I'll just flag this one. So this was a mental health professional who was on the receiving end of homophobic abuse. They said, there was a patient who was extremely aggressive towards me and extremely targeted me. I was new. Everyone liked the patient, so whenever I tried to speak to anybody about it, I would always get, oh, but he's ill. Oh, but he's such a lovely man. And the reason why I've highlighted this one is because this sort of comes into this same aspect of it's part of the job on a mental health ward that people will say things. And I think even well-meaning staff might say they didn't mean it, they're unwell, but actually that by hearing those things, it can be very invalidating for the staff member who's still maybe really distressed or even scared by what they've experienced on a ward. So this all created quite a barrier to staff accessing support that they needed. And on this slide as well, I'll just flag around some of the barriers to reporting incidents and concerns. So on the one hand, this might be around trusts all have reporting systems, IT systems for reporting incidents and things that happen on wards. So any kind of violent incidents, for example. But the same sorts of barriers kind of that prevent people from reporting incidents on those IT systems are also similar barriers to that prevented people from actually raising concerns about what was happening on wards or not being able to access the right support. So I'll just pull out a few of these. So there was a perception that when incidents are reported, when negative things are reported on wards, that nothing happens. So quite a lot of people reported an experience of having reported something, but never hearing anything back, whether that was what we're going to do about it, or we've noticed that there's a pattern going on and not hearing anything about that, or not getting any support in response. So just feeling like they've told what's happened, they've uploaded photos of injuries perhaps, but then nothing's come back. There was also some confusion around what the process was, or not necessarily having the right access to reporting systems. People were also frightened about kind of negative consequences when they did report things. And sometimes that was played into when there was frequently things that they were wanting to report. So, for example, verbal abuse, which happens a lot. If people were reporting each time that happened, they might have comments from colleagues like, oh, you've reported a lot this month. Do you need to report something else as well? So that was off-putting for people, feeling like they would have a negative response from colleagues or managers if they were to report another incident. But then that means that, as we said at the beginning, incidents tend to go underreported, and then trusts don't have the information that they need in order to better support staff. So that's just to give an overview of the findings. And now I'm going to hand back to Katherine, who's going to talk to you about recommendations that we've made from the study.
Okay, so following the interviews and the analysis, we held a stakeholder event. And we invited 41 people to represent various different areas, various different levels of expertise. So some of them were actually interviewees in the study, but we recruited additional people to that. So there were people that were actually staff on the wards, there were service users who got experience of being on the wards from our advisory groups for the study. But we also invited people with senior leadership positions in NHS England, in integrated care boards, and within the trust we invited people who were leaders in inpatient services, leaders in relation to staff wellbeing, or leaders in relation to EDI, and we also invited some staff from the network that Kate mentioned. There were a number of issues or a number of recommendations that come out of the qualitative interviews, but there were also some gaps. And we needed more work to think about how some of those recommendations might work in practice and how they could be operationalised. So we took a number of key challenges and we presented those to the larger group, who then split into smaller groups to think about problem solving and key recommendations in practical terms for each of the problem areas or each of the gaps. And what we've done with that is we've written it into a report, which is currently in the final stages of being drafted. And we've also made a short animation of the recommendations as well, which is also just being finalised. But what I'm going to do today is just present an overview of those different recommendations on different levels. So we split it into things that staff on the wards can do themselves, things that managers need to pay attention to, and also things that the larger kind of organisation or NHS trust need to do. Do you want to move on to the next slide, Kate? So first of all, if we think about recommendations for what each member of staff can do, I think the first is really bringing into awareness and thinking about, I guess, the impact that work on the wards and these serious incidents, and particularly those identity-based incidents, might be having on you yourself, but also on you, your colleagues. Now, in highlighting these recommendations for ward staff, we're not saying the onus is on the staff themselves to bring about change, because it's very much not, but it's about everyone doing what they can within their power of influence. So it might be there's changes that the staff themselves can make for themselves, for their colleagues. There's issues that they could raise higher up with the ward manager in order to help staff feel better supported. Because we know from the research that staff often feel unsupported, in particular in relation to identity-based incidents, and people are experiencing their colleagues not even acknowledging sometimes those events, and it probably wasn't from it probably was coming from a case of staff really not knowing what to say. But our research clearly highlighted that those staff that are on the receiving end of those incidents felt it was important that unacceptable behaviour was called out, and that wouldn't be offensive, that would be a positive thing. And it's also really important to, if we think about the impact of some of these events, to check in with colleagues after they've experienced things. So, just saying to someone you work with, how are you feeling because of that, rather than kind of brushing it under the carpet. It's just those little gestures that are really important. So checking in that after it's happened, but also the next day and thereafter. And just encouraging general conversations of wellbeing in the team. So it's something that's openly talked about. And it's important to remember to be inclusive as well, because as Kate said, the study found that a lot of support came from relationships within the team, which is great if you're kind of a member of the ward team and you're there all the time and you're part of that kind of cohesive network. But we were finding that people that weren't benefiting from that were those that were slightly outside of the main team, so domestic and estate staff, admin staff sometimes, or those allied healthcare professionals that came onto the wards more infrequently and worked across a number of different wards, or nursing, student nurses, junior doctors, or bank and agency staff who weren't part of their regular team. So it's important that members of that regular team remember to check in with those colleagues that aren't part of that kind of tight network, because those are the people that seem to be struggling in particular. And our earlier studies and in the qualitative interviews backed up the fact that organisations do have, or some organisations, certainly not all, but do have mechanisms in place to support staff, be that in terms of training that might be offered, be that resources such as occupational health, staff wellbeing teams and the networks. But what we find is people don't always know about these things because they're not very well publicised. So I guess on an individual level, it's about trying to find out what's out there. I'm not saying that the organisation doesn't need to do more in terms of publicising it, or some organisations need to do more in terms of providing more supports, but there might be things out there that you don't know about that would be worth exploring and accessing at least what's available. Do you want to the next slide, Kate, please? In terms of ward managers, as Kate said, it was kind of a mixed experiences in terms of what people were getting. So some people had very positive supports from the managers. So that suggests to us that if managers can do this right, then that can be a really important source of support, because it's kind of localised. Your manager kind of knows you, and it's very immediate. But managers were struggling in some respects, often for obviously time, but also not knowing quite what to say. But the things that people were telling us was important and worked well is when debriefs could happen immediately after an incident. Because as Kate said, debriefs often happened, a day later or several days later, and the people that involved, particularly those that weren't regular members of the team, such as bank staff, agency staff, weren't always around or available to attend. So it's important to do something sort of relatively in the moment. And also, it's not just the one-off support that's important, because some people continue to struggle. So it's important that the support's in place for people after the debrief as well, for those that want it. So a one-off debrief might not be enough for some people, given the severity of the event, or even not the severity, but given the individualised impact that has on a member of staff. And it's really important in that respect that managers continue to check in with people even after the incident, because they won't know whether the incidents continue to have an impact, including those colleagues that went on sick leave, because people often talked about feeling forgotten at that point as well, and not kind of thought about. Specifically in response to identity-based incidents, it's really important to, as a manager, to promote that culture where these things are acknowledged, and you as a manager kind of call it out as kind of behaviours that aren't acceptable, and to use incident-based reporting systems that exist to label these incidents as racism, as homophobia. And when we've done related research that's looked at serious incidents reports, and how they've been categorised, incidents that could potentially be labelled as racism, homophobia, discrimination against disabilities, they're not labelled in that much detail or in that way. And of course, if you don't label them, it doesn't allow opportunities for monitoring and therefore seeing where there's particular problem areas. And as a manager, you've got slightly larger power of influence, so it's important to try and bring the occurrence of these events and patterns to your colleagues and other managers and managers in more senior positions. As Kate said, people spoke in particular about their experiences of allegations and investigations and how they felt uninformed. So it's really important that as a manager, you keep people in the know and keep people informed about what's happening, even when they're on sick leave, because even though there's only so much you might be able to discuss, that continued contact's really important. And to offer supports where appropriate as well, be that psychological and emotional, or more practical in terms of sort of legal, where they can access legal support or financial support or union support. So it's not so much providing that support necessarily yourselves as managers or people themselves as managers, but it's knowing where to signpost people. And also thinking about the wider impact. So it's not just the staff that were directly involved, but it's going to have a ripple effect on other members of the team as well, and it's awareness of that. As a manager, as I say, you've got people who've got a high level of influence, so it's about creating kind of an open culture. And if you yourself as a manager can talk about these things and to your colleagues and acknowledge that it's been a difficult shift, how you yourself are feeling, and also, I guess, modelling good self-care, that's a really important message to give to the rest of the team. And using the spheres of influence to raise staff wellbeing, EDI issues to more senior people. And I guess because we know that certain groups, those that don't have those, benefit from those secure kind of relationships within the team are more vulnerable. So as a manager, it's keeping an eye out for those people that we know that might be particularly vulnerable, such as students, new staff, kind of agency staff, sort of even international staff as well. So it's I guess it's having an eye for those that might be more likely to be struggling or not benefiting from the kind of intrinsic supports within the team. Do we move to the next slide, Kate? So in terms of wider trust organisations, what can they do? I guess it's ensuring that in terms of management and leadership, that those senior people are present in clinical areas, and and that I guess in terms of leadership, that's diverse leadership. And we know that the trust has got, the demographics of the trust kind of represent the demographics of the population, but those people from particular ethnic minority groups aren't in the high leadership positions. And having those role models is really important. Managers and senior leaders also need to model that kind of open culture and acknowledge that there are problems within the trust rather than, I guess, pushing things under the carpet. It's important to ensure that managers and senior leaders who we found might be struggling to know how to kind of speak to people about these things have got appropriate training and support, and don't feel so overwhelmed themselves with the level of stress and responsibility on the wards that they can be support. They can offer support to other people that they manage. As I say, it's important in the sense of not pushing things under the carpet and recognising problems and recognising that racism and structural discrimination is part of that as well. It's important to have opportunities for leaders and managers with protected characteristics and minoritised groups to be able to listen to each other and what each other experienced and offering support. Things like reverse mentorship might be helpful. So when people from minoritised groups provide mentorship for those in leadership positions. And as leaders, ensuring that EDI is prioritised in genders, in strategy meetings, in operational meetings. And that services really do invest in staff wellbeing. So working with psychology services and ensuring that even when those services are there already, that people's time is actually freed up within work time so that they can attend. Or be about being proactive and not just being responsive to people's psychological stress or when people have got problems, but ensuring that those wellbeing initiatives are there proactively to prevent the occurrence of later problems. And in terms of training, trusts also need to ensure that there's adequate training to people in supporting others at the management level and how to put reasonable adjustments in place, but also training for all staff in things like identity-based abuse and the impact that it can have, and kind of cultural awareness and working with people and work and helping support people who might be experiencing these events. Okay, do you want to put the next slide on? Okay, so what next? On the success of that study, we managed to get future funding, again from the NIHR, where we're going to be putting some of these recommendations into practice and evaluating their impact. So we're going to be working with Lancashire South and Cumbria Traumatic Stress Service, who've developed a team-based approach for workplace trauma, but that approach doesn't specifically address issues that we were finding that were particularly prominent for staff from minoritised groups or particularly prominent for kind of inpatient staff as well. So we're looking at refining that model as the first part of the study and then rolling that out across 30 acute wards across England and comparing outcomes to 30 similar wards who don't have that same model. And we're looking at the impacts on things like staff wellbeing, staff absence, staff retention, and staff and service use of kind of patient perceptions of the ward atmosphere and staff sort of job satisfaction. So that study is due to start in June. We will be looking for people to contribute to our stakeholder events in terms of refining the intervention, and we'll be recruiting wards for the study across England, but certainly within Greater Manchester Mental Health Trust as well. Okay. Okay, so that's the final slide. So just a big thank you really to everyone that took part in our research, who shared their experiences, for our public and patient involvement groups which involved a staff group and a service user group, and to Emily Harris, who kind of carried this project through really as our research assistant. We've got time for questions now, but we've also put our contact details at the bottom of this slide, so if you wanted to ask any questions later, if there isn't time or if things came to you afterwards. Okay, thank you.
Great, thank you so much, Kate and Katherine. and we will start with some questions that got submitted ahead of time. But we do really encourage you to use that Q&A tab to pose any further questions as we go along. Firstly, we've had some comments on the meeting chat, which have been really helpful. First question I have here is, did staff talk about the support they received from the police?
Do you want to answer that, Kate?
I'll take that one. Yeah, thank you. Yeah, so some staff did talk about reporting incidents to the police, whether that was hate crime, so for example, kind of racially motivated, or just in terms of violence and aggression in general. So some people, this was kind of in the context of people wanting to, obviously wanting something to happen, wanting there to be some kind of consequences, I guess. What people said was that very often the response from the police was quite limited. So understandably, they felt that they would often get feedback basically saying, we can't do anything, as if somebody's on the ward, they're a mental health inpatient, that's kind of playing into that it's part of the job aspect again, so there's nothing really much that we can do. And often people felt that that was quite an invalidating experience from police. Some trusts or some wards did talk about having a really good relationship with their local police service, and there was maybe a liaison officer who they spoke to, and that would seem to be a better way of managing things. So having a way of police actually discussing what had gone on, discussing potential next steps, maybe even writing to the person who'd made the attack, for example, and actually sort of thinking about really highlighting that things aren't acceptable. So there was more of a process that was not about saying trying to convict somebody, but at least about having a response and saying, actually, this does fall under a hate crime, or this this is something that there will be consequences for. So quite a mixed response, but in general, where there were kind of liaison officers and a much closer relationship between the trust and local police services, that was something that staff found much more beneficial.
Thank you. We've just had a message from Carol in East London FT saying, thank you for seeing and hearing inpatient staff issues. I feel acknowledged. I thought that was a very important one to say thank you for taking part. I've had another question here. Are there any findings specific to all staff working on female versus male wards?
Oh, that's a good question, actually. I'm not sure off the top of my head. I can't think of any particular differences that came up from all male versus all female. So yeah, I'm afraid I'm not sure about I'd have to go back and look at the interview data on that one. But
cool. We've had someone ask, out of all the staff with protected characteristics that you interviewed, which group had the most difficult employment experience and why? It's quite a hard one.
In terms of employment experience, I assume that means just kind of experience at work. It's hard to quantify. This is obviously qualitative research, so I wouldn't be able to say there were particular groups that had a kind of significantly worse experience. But I would say that probably racism was the main identity kind of based experience that people had that was reported the most, and very frequently, and in terms of the sort of the challenge in terms of people accessing support. And I think in terms of job roles, it's probably a difficult one to quantify. So there's so many, it's such a nuanced thing. So difficult to add on that one. Katherine, I don't know if you've got any
Is it worth saying,
thoughts from your
was this something
research?
about people that got more invisible disabilities, that it was more about obviously not being targeted, but then about not the reasonable adjustments not being in place for people and not being taken seriously? So that was one difference, I guess, when it wasn't a visible disability.
Yeah, absolutely. And that's, I suppose, sort of feeling let down by their organisation or kind of managers, or feeling like their needs aren't being met by their employers as well. So it's a complicated picture.
Thank you very much. Were service users or PPI representatives included as key informants?
Do you want to answer that one, Katherine, or shall I?
Yeah, can do, yeah. So we didn't have people at PPI group. I'm sorry, we didn't have PPI or patient participants in the interviews, but what we did have is we've had an advisory group. So we had 2 advisory groups, one made up of staff, one made up of service users. So we took our findings to the service user group and asked people what they thought about what we found. And it's quite eye-opening, really, because we'd kind of saw things from the staff perspective. So it's quite good to take things to the service user group who pulled out things that we hadn't really thought out about, like what the impact of involving the police might be on the service users themselves, and their experience of the incidents and how they can be distressing for service users too. Which obviously we knew, but we hadn't kind of lost sight of that in sort of analysing our findings and making our recommendations. And we had service users involved at the stakeholder event as well when we were developing more specific operationalised support recommendations.
Thank you very much. We've had a question just come in from Katherine saying, did you include staff working on older adult wards, and were there any different perceptions or experiences when working with people with dementia?
We had, if it was older adults in terms of acute mental health, yes, we did include, but I think, Katherine, is it right, in terms of dementia and kind of more organic, was those wards were excluded?
Yeah, we excluded those wards, yeah, but we looked at acute older adult later life wards, but not wards for people with organic impairment.
Yeah, and I don't think we would have interviewed enough in order for me to say what any particular differences were in terms of working with older adults. But also in terms of the wider interest, we had a lot of interest in the study from people working in different services that weren't included, so forensic wards or from kind of community services. And yeah, it's certainly raised a lot of interest in terms of the challenges in accessing support and some of those issues around identity-based concerns that are, of course, very much across other mental health services. So in future, it would be lovely to try to do more work in this area in different settings as well.
We just had a kind of related question here. Was ageism included as one of the kind of abuses that were looked at?
We asked quite open questions about the types of things that people experienced, so we didn't necessarily kind of prompt with specific things. So I don't know that it came up as a sort of a significant theme in the interviews in what was raised by participants, but certainly we wouldn't have excluded it if it had come up. Then it would have been.
We did interview people of lots of ages as well. We kind of purposely sampled, so we ensured that our sample got a mix of people in terms of roles, in terms of ages, and in terms of genders.
Thank you. I know we're really cutting it towards the end, so I'll just do one last one. I know there's also been a lot of comments and statements that have come up in the meeting chat, so I apologise if I haven't acknowledged them verbally here, but we are taking a record of them as well, so we will read them and, if necessary, respond to them or reach out. So thank you. Final question I'll ask right now. Has the length of employment and experience had any impact on how staff perceived incidents and their severity?
Yeah, that's a tough one. I think, yeah, that was not a quick one for us to end on.
Sorry.
I'll try to give a quick answer. I think more junior staff or staff who've been in post for less time, perhaps were more happy to kind of discuss things and wanted more support around their experiences, but found it difficult to get that support. I think there is a sense that maybe people have been in the post longer because of that part of the job sort of culture, maybe even felt like they weren't even trying to access support anymore because of that sort of maybe ingrained kind of feeling that we just have to get on with this in terms of our post. So I think it's a tricky one. I think maybe newer staff or junior staff, particularly students and junior doctors, were kind of highlighted as groups that perhaps don't have as much support around them and perhaps need more support. But actually, I'd say the kind of longer standing staff members who've been in post a really long time, although they might be real experts in what they do, probably also need a slightly different approach in terms of really making sure that people feel able to get help and feel kind of giving permission to seek help and get that support. So
thank you. So I'm going to close there. I know there's a lot more questions and people have also been sharing some of their experiences on the chat. I really appreciate your time coming to visit this in your lunch hour. I'll just go, if we could go back a slide first so that people can see your email addresses if they want to get in touch, and we'll just leave that there for a couple of seconds. I know there were some questions that people had that maybe weren't fully expanded upon, or suggestions or experiences that you wanted to share. So these are ways that you can get in touch. And I'll also show you the more generic email address that we have for research and innovation at GMMH if you'd like to contact us there. So then if you go forward 2 slides then, please. Just to close off, again, thank you so much for attending today. Research and Innovation have their own section of GMMH's website where we have an interactive library of all of our active studies that you can go and browse. You can browse it by condition or type of participant and see the participant information sheets, how you can get involved, what's going on. We really do encourage people to go and have a look at that and see the variety and volume of research that is taking place at Greater Manchester Mental Health. We've also got our own social handles where we share published research, new studies that are starting. So we would be grateful if you could give us a follow. We will add more webinars per month as we go along this year. So we will try and keep you all updated about what those will be. And I will let you go and enjoy the rest of your afternoons and your weeks. Have a lovely rest of your week and weekend. Thank you all. Bye.
Thanks very much, everyone.
Thank you.